Hi everybody, I'm Dr. Andy Heiberger and welcome to the Recovery Channel. As you know, we've been demonstrating a few videos with information about the disease of addiction and alcoholism, and we've been trying to get the word out about a lot of things about this disease. I want to encourage each and every one of you out there watching to follow us on Facebook, and you can ask us questions, you can give us feedback, and you can let us know what other topics you'd like to hear about. Today I'm going to talk a little bit about medications that are used for the treatment of alcoholism. There are a number of new and a number of old medications that are used to treat this disease, and I want to make you aware of it so that you can be well informed when you talk to your doctor about your alcoholism. I'm also interested in addressing any medical professionals that might be in the audience. I want you to understand that there is a lot of information, and you can prescribe for your patients with alcoholism and do a lot of good for them to treat their disease. Before I get started with the slides, I want to thank Ron Horn and MediaScript for providing the expertise and the equipment that makes all of these presentations possible. It's a tremendous gift, not only to the recovery community, but to the medical community as well, helping us to spread the information that really isn't known out there about the disease of addiction and alcoholism. One of the things that I tell my patients in treatment at Shepherd Hill is that by the time they finish a month or two of treatment in our treatment center, they know more about the disease of addiction than 90 to 95% of all physicians. And that's actually a sad truth. We don't spend a lot of time learning about it in medical school, and most doctors don't like to treat alcoholics and addicts, primarily because they think the disease is untreatable. Of course, we know different, and that's part of what we're doing here on the Recovery Channel, is teaching you and the medical community what can be done about this devastating disease. As I said earlier, I'm going to talk today a little bit about medications. And there's a number of medications that have been approved by the FDA for the treatment of alcoholism. The first one is Antabuse. It's a drug that's been around since the 50s. There's another medication called naltrexone, and it's available in two forms. One called Revia, which is an oral tablet, and the other, which is Vivitrol, which is an intramuscular injection. There's another new medication now called Camprol or acamprosate. And I also want to cover some of the newer drugs and newer agents that are being used to treat alcoholism. The anticonvulsants are a group of medications that are getting some testing, really, to see if they're effective in treating the disease of alcoholism. Now, Antabuse or disulfiram is a drug that some people have heard about. You've probably understood or heard about someone that has either been treated with it or know about what it's like. But basically, the idea is if you take Antabuse and you drink alcohol, you get really, really sick. And that's exactly what the purpose is. It's a form of what we refer to in medicine as aversion therapy. In other words, we give you something that's going to give you an aversion to drinking alcohol. So every time you drink alcohol, you get really sick, and then that teaches you supposedly to not drink alcohol. The only problem with this, of course, is it doesn't work, because alcoholics can't be punished into sobriety. You can't sicken someone into sobriety. And in fact, what you really need to do is treat the underlying disease of alcoholism. But I want to talk a little bit about the disulfiram or Antabuse, just to give you a flavor for what we did in the past for this disease. The disease causes all kinds of unpleasant symptoms: drop in blood pressure, flushing, high heart rate, sometimes high blood pressure, severe headaches, nausea and vomiting, agitation, muscle aches and pains, and lethargy if you take the medication and drink alcohol. The interesting thing about it is your body becomes so sensitive to alcohol that even an incidental exposure to alcohol with Antabuse on board will make you very, very sick. So getting a whiff of someone's hairspray or using hand sanitizer and inhaling a significant amount of the vapor will actually make you quite ill. And that's because the body is very sensitive to a byproduct of alcohol metabolism that accumulates in the presence of disulfiram. The mechanism of action is that it inhibits an enzyme called aldehyde dehydrogenase, and then alcohol is not normally metabolized. This isn't really important from an educational standpoint, but basically the point is it makes you very, very sick. Some of the side effects: it can make your liver damaged, it can cause sedation, increased depression and psychosis, impairment of your thinking, and worsening of dementia. Doesn't sound like a very good idea for a medication to take for someone with the disease of alcoholism. So we don't use it at all in treatment of alcoholism. I mention it really as an item of historical interest only because some places do use it and some doctors actually prescribe it. It may be effective in chronic heavy drinkers that don't have the disease of alcoholism in getting them to cut back. But more than likely, an alcoholic will not respond to antabuse. They'll either take the antabuse and drink and get sick, or they'll simply stop taking their antabuse when they want to drink. So it's not particularly effective. The new medication, or it's really not that new, actually, naltrexone has been approved for quite a number of years for the treatment of alcoholism. I want to talk about this medication because of its remarkable effectiveness at reducing cravings for alcohol, either in the oral formulation or the new formulation, Vivitrol, which is a product actually produced here in Ohio that is injected and provides a drug level that lasts for an entire month. This medication is used in patients who can meet the criteria for a diagnosis of alcohol dependence, patients with a positive family history. They have a lot of physical cravings for alcohol, and also patients that get what we refer to as a strong subjective reward from alcohol. And they're also desiring to be in recovery and willingness to engage in a treatment program. Interestingly enough, there are a number of patients who get virtually no benefit from naltrexone. And there may be a genetic determination for who's going to respond to naltrexone and who's not. We don't have the ability really to figure that out yet today, but someday we will actually be able to do genetic testing and determine if naltrexone or perhaps a different medication will help alcoholics reduce their cravings for alcohol. So we don't use it in patients with hepatitis or liver failure. Obviously, we wouldn't give it to someone who's on some kind of opiate maintenance because it's an opiate antagonist. And they're usually, it's not a good idea in someone who needs to take opiates, obviously, because of the way the medication works. I'll talk about that in a minute. The reason that naltrexone works is it blocks the mu receptor in the brain. The mu receptor is the receptor in the brain that gives the reward sensation from the use of opiates. And it may in some way carry the message of euphoria from drinking alcohol. And by blocking that receptor, we seem to see a significant reduction in cravings. It blunts the reward of the use of alcohol, and it reduces cravings, like I said, in a significant number of patients. And it has been FDA approved for the treatment of alcoholism for some time. Now, you may remember, if you've seen some of Dr. Whitney's presentations on the use of naltrexone for opioid addiction, that it's also used for that condition as well. And particularly in patients with alcohol and opioid addiction, this drug is very effective at reducing cravings and improving outcomes over the long term. And why do I want to spend time talking about this medication? Well, I want to talk about it because this is an easy drug to take, an easy drug to prescribe, and it is very effective at helping alcoholics to not drink. A lot of the studies not only show that it increases the number of days of abstinence, but because it reduces the reward produced by alcohol, those who continue to drink a lot less when naltrexone is present. So it's an important thing for any primary care doctor to understand that if he has a patient who's drinking too much and having problems, this medication can be used and used very safely. It doesn't produce a negative reaction. It simply reduces the reward or euphoria that the alcoholic experiences when they drink alcohol. This slide shows a little bit about how the medication works. There are endogenous opioids or endorphins operating in our brain, and they give us a sense of pleasure, euphoria, pain relief. And what the naltrexone drug does is it blocks those receptors so that signal doesn't get through. Here's a picture of the tablet. And here's a picture of the medication that's available for injection. And here's a fancier looking slide that shows exactly what happens when Vivitrol is introduced into a patient. Normally what happens is the endorphins are released with the consumption of alcohol, and that leads to the sense of pleasure and euphoria that alcoholics experience. And by blocking that with the medication, we find that they experience less euphoria and they're less likely to drink or drink heavily. Here's where they get the injection. It's a big injection. It's kind of painful. Has to go all the way through to the muscle, but don't let that deter you. The technology behind the medication is really quite fascinating. It's the first truly effective long-term injection dose that maintains a very steady state level of the drug. There are carbohydrate microspheres that are filled with the drug, and those are injected into the patient's muscle. And over time, what happens is those carbohydrate spheres are broken down by enzymes in the blood, and the drug is slowly slowly released and absorbed over the next 28 days. So what we find is that patients had fewer heavy drinking days and had higher numbers of abstinent days when they used the medication. Some side effects: nausea, vomiting, headache, fatigue, dizziness. The most common side effect is pain at the injection site. It is a deep intramuscular injection and can sometimes be uncomfortable. But this drug is highly effective at reducing cravings for alcohol. And it's really, really something that you should talk to your doctor about. If you're having problems with your drinking, then it's definitely something to consider. Camprol, or acamprosate, has recently been released for treatment of alcoholism, and honestly, we had a lot of excitement about this drug when it first came out because it helped to balance some of the brain neurochemistry of early recovery. The medication was hoped to be a bit of a miracle drug for alcoholics in early sobriety, but it's turned out not to be all that effective. It is helpful in many cases, but it's not the panacea that we once hoped it was. The way the drug works is it helps to balance brain chemistry in early recovery, and again, similar selection criteria for patients with the disease of alcoholism to use Camprol as opposed to using naltrexone. There's also, just as an aside, there's no reason not to use both medications. And sometimes our patients who have end-stage alcoholism, who are very much struggling with their disease, will often use both medications simultaneously. So there's no real difference in this drug. The big advantage that this drug has over some of the other drugs is it's not metabolized by the liver, so it's very safe even in patients with significant liver impairment, as alcoholics often do because of cirrhosis. So if you remember, if you saw my presentation on alcoholism earlier, you saw I had a little bit of a seesaw operation going, showing the balance of neurochemistry that goes on in acute intoxication, during the adaptation stage, and during withdrawal. And the idea behind this medication is it attempts to rebalance that. And what happens is when alcohol changes those neurochemicals, and then with chronic alcohol use, the adaptation occurs, and then during withdrawal, that medication, glutamate, is significantly increased. And that's what causes the withdrawal symptoms. This is a little slide that shows the glutamate molecules being released from a nerve ending and how they affect the subsequent nerve. And in alcohol withdrawal, there's a very high level of glutamate present, and that's again because of that seesaw operation, which you're going to see here in a minute. What Camprol does is block some of that glutamate effect, and that reduces the acute withdrawal symptoms. Here you can see in this slide the normal situation where the brain is in balance. When alcohol is present, then we achieve intoxication, and over time tolerance develops and the brain adapts to that by increasing the amount of glutamate present. In withdrawal, that excessive glutamate level is responsible for a lot of the symptoms of early, or what we call even the protracted withdrawal syndrome. Camprol helps to balance that, and that's proven to be very exciting and effective. We find that in 42 and 52-week clinical trials, the number of days abstinent was significantly improved with acamprosate compared to placebo, and that makes us very excited about using this medication in our alcoholic patients. Most common side effect is diarrhea from it, and about 10 to 15% of the patients can't tolerate the drug because of that reason. Otherwise, the effects are very mild. The biggest disadvantage of it is it's 2 tablets required to be taken 3 times a day to get an effect, and so that's a lot of pills to take, and sometimes our patients don't like swallowing pills all that much. Just as a cost comparison, because this is a significant part of medical care, the rough costs are listed here of the various medications. Antabuse is about $100 a month. Naltrexone, $50 to $150 a month. Vivitrol, that says $700 and $750. Actually, Vivitrol's recently raised their price. It's up to $1,300 a month. That's pretty expensive. And without insurance coverage, that puts it out of the reach of most people. Camprol's about $125 a day, and it's or $125 a month, and it's a reasonable choice. We tell patients it's about the same as a pack of cigarettes a day. So some other drugs that are not specifically approved for the use in alcoholism that have been shown to be effective are in a class we refer to as anticonvulsants or anti-seizure medications. One of those is Topamax or topiramate, another Tegretol and Depakote. They've been used. Sadly, they haven't been found to be particularly effective. They make sense from a biochemical standpoint that it would actually make a difference and help these patients, but it's turned out that it really hasn't made that much of a difference. Some preliminary studies have shown that there's an advantage in using these drugs, but most of the follow-up studies have failed to show a lot of benefit, and so we're not using them that often today. Someday we may get better research, we may get better anticonvulsant medications that make a difference. These drugs all work in the same part of the brain that alcohol has its effect in the GABA and glutamate balance, and so we believe that they work based on that, but unfortunately the evidence isn't real strong for it. And topiramate or Topamax has been used. We don't use much of it anymore because it really has not been shown to be particularly effective. But it does have significant effects, like I said, on that GABA and glutamate balance, as well as working in the limbic system to modulate dopamine release. Some of the side effects: sedation, dizziness, tingling. It's a relatively benign drug, but there are some side effects that patients won't tolerate, and so we use it when it's well tolerated and it appears to be having a benefit, but that's not, unfortunately, very often. Some other agents that are getting some press right now, baclofen is an antispasmodic drug. It's really not been shown to be very effective in the treatment of alcoholism. It's been studied. Baclofen has also been shown to maybe be effective at reducing cravings for cocaine. Again, questionable studies without a whole lot of strong evidence that really makes us want to do it as a consistent practice. The SSR agents, the selective serotonin reuptake inhibitors, some of the antidepressants, have been shown to be of some benefit, but it's very challenging to tease out whether these drugs actually are making a difference in patients' outcome with alcoholism. Zofran is an interesting drug, ondansetron. It's a drug used for postoperative nausea and vomiting in the recovery room. It's also used to treat cancer nausea. It's very effective. It's a serotonin blocking drug, and it reduces nausea and vomiting because of its blockade of serotonin. And there is a significant body of evidence starting to develop that Zofran may turn out to be a drug that in some patients is as effective as naltrexone is in others. It appears that the patients who respond to Zofran don't respond to naltrexone. And again, it's very likely a genetic difference. And so one of the things that we're looking at right now is doing genetic testing that will help us determine what drug would be appropriate. In some patients, Zofran will be the choice, and in others, naltrexone may be the choice. And in still other patients, hopefully, there will be other agents that we develop over time that will be of help to these patients. And the last medication is varenicline or Chantix, which is an alpha-4 beta-2 nicotinic receptor or partial agonist. And that's a drug that you may be familiar with as treating smoking addiction. In fact, it's used very successfully in smoking cessation programs. Interestingly enough, the same neurochemical, acetylcholine, is involved in some of the pleasure reward circuitry in the brain in exactly the same place where it works for smoking cessation. And so there's been a number of studies done that have shown benefit to using this non-smoking drug to treat alcoholics. It's particularly effective in alcoholics who smoke, or smokers who drink. There have been a couple of studies that have shown it in non-smoking alcoholics to be very effective. And so it's a very exciting time right now to be looking at some of these new agents and realizing that there's going to be some new treatments available for our alcoholic patients. Again, the reason I wanted to talk about medications is twofold. I want to put the information out there for patients and for their doctors to understand that there are effective medications available to treat the disease of alcoholism. But more importantly, we have medications to treat this disease because it's a disease that can be treated. Makes sense when you think about it that way, but the truth is a lot of physicians and a lot of people, a lot of patients, think that their alcoholism is a hopeless, untreatable condition. We in medicine can help. Now, nothing replaces a strong recovery program based on abstinence, no question about that. But the truth is, medication can help. And if we can help patients get through those difficult early months where a lot of relapses occur, we can go a long way to helping patients overcome their alcoholism. And that's all I have today. Thanks for watching the Recovery Channel. I'm Dr. Andy Heiberger, and welcome back soon.